I'm going to be in a hurry if they're tough questions.
Okay. First question, what can the VA do to enhance the bidirectional flow of information for care provided by non-VA physicians, since the VA electronic health record does not communicate well with non-VA informational systems?
Yeah, we've got to fix the electronic health record. I mean, we were a pioneer in the electronic health record. I want that health record to be so good that every one of you will want to use that record as your personal record, your private form of record keeping in your operation. When I first met on the electronic health record, I met with our IT department and our doctors, the people who had worked on it, and I thought it was a pretty doggone good record. So I said, you know, this is really a terrific idea. How do we commercialize this so we make some money off of it? And he said, you know, you're wearing your Procter & Gamble hat again. We want to give this thing away for free because we want everybody to use it. And the more people we have use it, the more we can crowdsource the innovation. So we want to make it usable for you. If you have suggestions, let me know what they are. And I'd like to get more and more people to use it because I think the future of American healthcare is this kind of participatory system that we're going to have.
Thank you. Next question. There is broad external and internal stakeholder concern about the VA's work on its new policy document, the VA Nursing Handbook. The American Society of Anesthesiologists, the Vietnam Veterans Service Organizations, and the VA's own chiefs of anesthesiology are among those who have urged the VA not to endorse this new policy. The doctor's writing. Can you provide an update on the VA's work on the nursing handbook, what the time frame for publishing the Federal Register, and avenues for input?
You know, that's strange because I was at Johns Hopkins School of Nursing the other day and they told me everybody was for this idea.
Welcome to Texas.
Yeah. Listen, the reason we put out these ideas is to get your feedback. And so Dr. Carolyn Clancy, our interim undersecretary, and I are thrilled with the feedback we've gotten. We're going to study it. We're not going to rush into anything, and we appreciate the feedback, so keep it coming.
Thank you. A major part of your job description is to advocate and make happen the high quality and timely access to care for veterans both inside and outside the system. Private physicians are still having a lot of red tape and inefficiency in trying to care for our veterans. How do you plan to get down to the level where care is provided to address and improve this?
Yeah, I mean, as I talked during my prepared remarks, we only have one mission, and that's to care for veterans. And we should look at everything we do through the eyes of a veteran. They're our raison d'etre. They're the only reason we're here. And so we're going to undertake the largest reorganization in the history of VA. That reorganization is going to involve changes throughout the organization. We're going to knock down the barriers between our three siloed administrations. We're going to create a customer service organization so that veterans will know who to contact, and those people in that organization will be able to navigate them from benefits to health care to cemeteries, hopefully not to cemeteries after health care. We're going to create a shared services operation, so we're going to pull the shared services out of the siloed administrations so they can focus on one thing only, and that's the care of veterans. We're going to create regional directors who will have responsibility across the three siloed administrations. Right now, the only place VA comes together is at the Office of the Secretary. That makes no sense at all. It's customer unfriendly because the customer needs an integrated organization much closer to the customer than that. I discussed this in a little bit more detail in an interview I did with Scott Pelley of 60 Minutes. That'll be aired tomorrow night. One thing you should know about this reorganization, this is not me sitting in Washington coming up with it. This is multiple teams of employees from the lowest levels of the organization, including our doctors, including our nurses, coming together on teams to come up with the ideas to make our organization much more veteran-centric.
Thank you. A related question. Would you consider implementing an internal monitoring program, a secret doctor, if you will, to test the true responsiveness of fee-basis programs to treatment requests? Where I work, the phone numbers provided are not answered, and even the simplest requests languish.
I'm not sure I understood the entire question, but we have to take responsibility for the outcomes for our veterans, whether they're in our system or in a private sector system. So certainly we are not going to be eager to send a patient to the private sector if there's any risk on the quality of that care. We've got to take responsibility for that. As a result of that, there's a qualification process. It's not arduous to be able to get attached to either Tri-Health or Tri-West or the two providers that we're using, and part of that process is so that we can stay connected. One of the things I did when I first got into this job was at my first national press conference, I gave out my cell phone number, and I get calls from veterans every single day, and texts as well. And I did that on purpose because I wanted to demonstrate to the people in our organization, I felt so strongly about caring for veterans that I wanted each and every veteran in this country to feel free to call me on my cell phone, and they do. And that's the way we've got to take care of our veterans. I'm not sure I answered your question entirely because it was kind of long and I had trouble hearing it.
Sorry, I think you got a good chunk of it, but I'll paraphrase a little bit of it. I think some of the frustration that private physicians are facing when they interact with the VA is that they find the bureaucracy to be difficult to insurmountable.
I agree with that.
You know, so what are you
No,
going
I
to do to
agree.
fix it?
We've got to tear down the bureaucracy, and the bureaucracy's got to realize we have one mission. The way I've talked to VA employees is that generally around the world, if you thought of my role in the Procter & Gamble company, you would probably think of a pyramid, and it would look something like this. You probably might not be able to see that from the back, but it's a pyramid. And on the base of the pyramid, you've got all the customers you serve, and you probably, for a company, would have a sales organization of the people who interface with the customer. And you'd probably think this the CEO's on the top. But in a really customer-driven organization, the pyramid looks like this, where the customer, the veteran, is along the top. You have a customer service organization that takes care of that veteran, and it's the role of the hierarchy and my role to do everything I can to help the people within the pyramid to care for the veteran. So that's the way I view my job, and that's the way I exalt the customers that we serve.
Thank you. A related question to the two private contractors that you mentioned. This comes from a physician who is also a vet and asks whether doctors who are veterans will get priority in contracting under those arrangements.
You know, that's not written into the law, but I think it's a darn good idea. I mean, if nothing else, our veterans like going to veterans who are doctors. So in that sense, I'm sure the word will get out just like it did about my cell phone number, and there'll be a certain standing preference for that doctor who is a vet. But it's not written into the law.
Thank you. I assume this is also related to those two private contractors. Many of our primary care colleagues are receiving unsolicited contracts from the VA asking them to provide services at financially unsustainable levels, well below Medicare rates. They're not able to participate at this level. How can you address that?
I can work to help them get their costs down, get their cost structure down. Those levels have been established by the government. Those are the levels. And if you're not meeting those levels, there must be some reason that the government thinks you have a very costly operation.
Be nice.
If you don't like that answer, I'm happy to help in any way.
We have a guest. Be nice.
No, also I have to say, I shouldn't have said it that quickly, because I do have to say I know we do have issues on insurance reimbursement. One of the things I've been pushing since I've been in this position is mental health. we have huge issues in this country on providing mental health. And on my first trip to recruit at a university, I went to Duke University Medical School. There were 17 residents in the room. Only one was a mental health professional. So knowing the number of mental health professionals we need because of PST, TBI, and all the other mental health issues we face, I asked the question, why aren't there more students going into mental health profession and medicine? And I was told that the reimbursement rates are not sufficient. And so I literally said, well, what role can I play from whatever bully pulpit I have to make the American public aware that we have real issues in mental health? And I then went to Massachusetts General, and I visited an operation called Home Base, which the Boston Red Sox do to help veterans who have TBI or post-traumatic stress. Talking to the president of Massachusetts General, he told me they lose $100 on every patient, mental health patient that walks in the door. So if the feeling is that the rates that the government reimburses are too low, I'm happy to use my bully pulpit, my convening authority, to help attack those, because I think certainly that's the case in mental health. I'm not as familiar with all the other specialties.
Thank you. I'm aware of your time schedule. We have a few more that I think will still fit in if
I'll
that's
answer
okay.
quickly.
Okay. No, you have time to deal with a few of these. There's a question about the transition after 60 days of care between the non-VA provider and the VA system. There's a concern about information getting back and forth, how the handoff is done, and really a two-way thing, how docs will get feedback down the line, how that patient is doing, and whether there's a need for further interaction.
Yeah, again, I think this is a big issue that we've got to sort through, but I also think it's the future. So we've got to figure it out. We do it today. We have situations today in the VA where somebody will get care in the private sector or from another one of our facilities and then come to a different facility. We have occasions where we partner with the Indian Health Services and the same thing occurs, or we partner with the DOD. Many of the docs who work in the DOD also work in the VA. So we've got similar situations where a person's being treated away from the VA and we've got to catch up the medical record. But this is going to really test us, given the amount of it. So we've really got to figure this out and working together.
Thank you. Next question is regarding the VA attention to women's health issues, particularly reproductive health and mental health issues.
This is another one of my top priority issues. Today, we have about 11% of veterans that are female. The DOD right now is between, depending on what part and how you count it, between 15 and 20% female. Most of our buildings were built in the 1950s, 60s, and 70s when there weren't that many female veterans. We don't have the gynecologists we need. We don't have the pediatricians we need. We don't have the space we need. So as a result, we've been working on an accelerated basis to try to create that. I mentioned earlier the work I did with Morehouse College of Medicine. And one of the things that we're working on together is we picked up a building at Fort McPherson. As the wars end, the DOD shrinks down, there's an opportunity for us to pick up facilities and as well as medical professionals. We picked up a building at Fort McPherson and we're turning it into a women's medical clinic. You know, it's true the women don't want to go in the same doors as the men. We see that not only in some of our medical clinics but also in our homeless programs when we shelter women. And as a result, we're creating this building there to be a women's health clinic, working with Morehouse and Emory to do that, to staff it with the appropriate doctors and nurses that it needs. I think that's the future.
Thank you. A question about how is the VA addressing veterans exposed to sarin, mustard gas, Agent Orange, who served in Iraq and years before at Fort McClellan before current knowledge?
we have several of these issues outstanding. Fort McClellan, Camp Lejeune water system. You know, as the science catches up, we end up then counting the case as a service disability. That was done with Agent Orange. for people from the Vietnam era, and as a result of that, there was a huge increase in demand on the VA system. It's one of the things that created the dislocation between supply and demand. It was fighting a war for 12 years. It was the discovery of things like post-traumatic stress, which was a condition that was never claimed by a Vietnam veteran because the science wasn't there. Now that the science is there, we have Vietnam veterans claiming post-traumatic stress legitimately. And so we've got to continue to work on the science. The one piece of science I've been spending a lot of time on with Dr. Victor Zhao of the Institute of Medicine, his people, Carolyn Clancy, Interim Undersecretary, is this whole Gulf War. I sat down with Ron Brown a couple of weeks ago. Carolyn was with me. We went through some of the demolitions that were done during the Gulf War. It happened to be my unit. I wasn't in it at the time, but it was Charlie Company, 1st of 504th, the 82nd Airborne Division, that blew up a trove of sarin gas shells. We need to go find, with DOD, we need to work with DOD to go find all of those instances, and then we needed to go find all of those veterans, and then we need to determine what those conditions are that we will provide support for. We're in the process of working through all of that.
Thank you. Two more, which will fit with your schedule, I believe. Why is the VA trying to separate itself from university hospitals? Or I guess, is the VA trying to separate from university hospitals?
Absolutely not. I don't know who asked that question, but that's the one thing I've been trying to do, is every time I go to a VA facility, I meet with the local dean of the medical school, and I talk with the deans of the medical schools as how we can create stronger partnerships. One of the things I'm demanding is that our second strategy, our second and priority strategy, is strategic partnerships. We cannot do this by ourselves. We need to embrace strategic partnerships. And I don't care what's happened in the past, but the future is all about strategic partnerships. So if you want to partner with us, our door is open, and we want you to partner with us because we cannot do this by ourselves.
Thank you.
And I'm excited about these partnerships because, you know, if you're out there and you run a medical school, you need to partner with us. We can help fund your research. We spend $1.8 billion a year on research. Yes, I'm selling. We can hire your students. We can provide residencies for them. And if you want to do clinical work, this is the place to do it. One of the things you'll see if you watch 60 Minutes tomorrow night, I hope, I don't get any editing authority over what Scott puts on TV, is our Million Vet Blood Bank. We have a Million Vet Blood Bank where we've taken the genome of all million vets. So if you want to do research, I can't think of a better place to go. And we'd love to have you do research with us. So research, education, clinical work, we do it all. We want to be your home, or at least your partial home.
And if the football game goes late, you'll be able to go to the Ebola session and still catch him on 60 Minutes. Last question. As a primary care physician, I treat many patients with VA benefits. Some have easy access to the VA, some don't. Some have fairly difficult access. Most would like me to manage their primary care. Will I be able to do that now?
I didn't get the last one.
Will I be able to manage the primary care? Will the vets be able to choose to have their primary care done in the private sector?
Yes, if they meet certain criteria. The criteria are 40 miles from a VA medical center. The criteria is waiting over 30 days for an appointment. And the criteria, obviously, the most important criteria is what does the veteran want? And a large number of our veterans don't want to go to the private sector, but also, on the other hand, a large number of the most recent veterans, Iraq and Afghanistan, are settling in rural areas. And in a lot of those rural areas, we simply don't have the coverage that we need. We have mobile vans that we're using. We have smaller clinics we call community-based outpatient clinics. And we're using a lot of telehealth, and we're going to continue to use telehealth. But reaching those rural veterans becomes difficult, and those are probably the ones who will probably seek primary care outside the system.
How about specialty care?
Specialty care, too. I mean, again, the same principles, But, you know, again, let me come back to one single thing. I don't write the laws, but one of the things I can tell you about the department that I'm in charge of, we only have one measure that counts, and that's outcomes for veterans, positive outcomes for veterans. So if a veteran wants to see any doctor in the room and for some reason it doesn't work out, we will do our best to accommodate that veteran as long as it's not against the law.
Mr. Secretary, thank you for coming.
Thank you. Thank you very much. Thank you. Thanks for all you do. Thanks for taking care of America.